Well, thank you to Dr. Boris for that fascinating presentation on cow's milk derived fortifiers. I hope our attendees were enlightened by his lecture. And if you have any questions and clarification, please send us your questions on the chat and we will share it with Dr. Boris to answer. Before I open the next session, I would like to acknowledge once again the support and participation of the following organizations: Children's National Hospital from the USA, Children's Hospital of Philadelphia, USA, PIC Pharmaceuticals, Toby Pharma, Roche, and Prolacta. We also urge our attendees to visit the booth for supporting organizations. If you are interested in their products and services, please feel free to drop a message on the chat box. The representatives for each of these companies are eager to meet you virtually. Our next session will be on ventilation in neonates. The speakers for this session are affiliates from the hospitals, which were among the top-ranked pediatric hospitals in the United States of America. Our chair for this session is also a very competent individual who is the recipient of many awards and honors. He's an American board certified pediatrician and neonatal perinatal medicine, and also a concurring American board certified in medical quality. He's also a fellow of the American Academy of Pediatrics and fellow of the Royal College of Physicians in Canada. He also has an honorary fellowship of the American Austrian Foundation. Ladies and gentlemen, let us welcome Dr. Junaid Khan. Good afternoon, Dr. Junaid Khan. The session is yours.
Thank you. Thanks a lot, Vincent, for a nice introduction. Without further ado, we will start the session. We will have a very nice morning session with respirology with Dr. Ola Sagastar, Dr. Raymond, and Dr. Ayman Rabani. So we continue with the ventilation aspects of this premature, and it's my pleasure to introduce Dr. Eduardo Bentlari. I must tell him he don't remember it. He's the first one who teaches about the ventilation when I was working. I was fellow in North Shore University Hospital. So Dr. Bentlari is a project newborn professor, pediatrics and OBGYN and director division of neonatology at the University of Miami. He's graduate from the University of Chile, and then he did his pediatric and respiratory physiology and joined the Department of Pediatrics at the University of Miami. He served a numerous professional organizations. Dr. Bentlari has several national and international awards and career achievement research award. Dr. Bentlari and his collaborators have developed one of the most prestigious neonatal program in the USA. He's contributed to many manuscripts and more than 300 papers and book chapters in the areas of neonatal respiratory physiology and lung injury and respiratory care. He is the editor of Newborn Lung, published by Elsevier. Dr. Bentlari is the recipient of 2003 Virginia Edgar Award from the American Academy of Pediatrics. So Dr. Bentlari is going to talk about in this session the strategies to minimize lung damage associated with invasive ventilation in premature infants. Very important topic. Dr. Bentlari, very welcome to you.
Good morning, good afternoon. And first of all, I would like to congratulate Dr. Junaid and Ayman for planning this great international conference, very successful. It's an honor to be here, although I would prefer to be in person with all of you. So we're going to talk about ways of minimizing lung damage in premature infants who require invasive mechanical ventilation. Dr. Stetson already spoke about non-invasive respiratory support, so most of my comments will be related to invasive ventilation. I have no disclosures related to this presentation. So this curve shows what has happened with survival of babies of different gestational ages over the last 20 or 30 years. And obviously, we are very proud of the fact that babies of extreme low gestation are surviving at a much higher rate now. The initial increase in survival in this extreme premature population was clearly related to the use of mechanical ventilation that was introduced in the late 60s, early 70s in babies that were not as small, but gradually we have been using mechanical ventilation in smaller and smaller infants. And the consequence of this increased survival of the more immature infants is that those complications that are associated with extreme prematurity are more prevalent today because the number of babies surviving is much higher. So one of those complications is bronchopulmonary dysplasia, that, as we can see in this slide from the neonatal network, is strictly related with the gestational age. The more immature the baby is, the higher the BPD, so that in babies who survive after being born at 23, 24 weeks, the incidence is usually more than 40 or 50%. So the question is, why do these small babies develop bronchopulmonary dysplasia? And there is ample evidence from animal experimentation and clinical data that shows that mechanical ventilation with intermittent positive pressure is a very important factor in the development of BPD. The other factor that Dr. Sokstad has done a tremendous amount of research over the years is oxidative damage, because we usually have to give higher FiO2 in the inspired gas to these babies. And the other factor that is also associated with a higher risk of BPD is infection, either antenatal related to maternal chorioamnionitis or postnatal. So most of my comments then will be directed to methods to reduce the damage induced by mechanical ventilation in this population of extremely low birth weight infants. Without any doubt, overdistension of the air spaces is one of the main mechanisms of damage in these lungs. Not only because it will produce a risk of interstitial emphysema and pneumothorax that are the most obvious immediate consequences of overdistension, but overdistension will also trigger essentially an inflammatory cascade because of endothelial damage. We have to keep in mind that when we are stretching or overstretching the lung, we are also overstretching the capillaries in the lung. And that produces endothelial damage that ends up with adhesion of polymorphonuclear, activation and release of inflammatory mediators. This overdistension and stress of the capillaries also can increase the permeability of the vessels, leak of protein into the interstitial and alveolar space. This produces surfactant inactivation that leads to low compliance, and we enter then into a vicious cycle where the more we overdistend the lung, the higher the pressures we use, the more damage we induce, and the more pressure we have to use then to achieve ventilation and oxygenation in this baby. So excessive tidal volumes, without any question, is one of the main factors in the pathogenesis of lung injury and BPD, and that's why we have to be so careful monitoring this. So because of this association between mechanical ventilation and lung damage and BPD, there has been a very large list of different modalities of mechanical ventilation. And what is striking is that there are very few well-controlled prospective randomized trials comparing these different modalities of ventilation. So I'm just going to concentrate in a few points that I think that are evidence-based on how to use conventional ventilation, limiting or reducing the damage. I'm going to talk about synchronization. I'm going to talk about volume targeting, and I'm just going to mention briefly high frequency ventilation at the end of this presentation. So for many years, when we ventilated babies early in the era of neonatal intensive care, we wanted to control these infants. So we wanted to see them quiet, and we used then hyperventilation or muscle relaxations and sedation to take over their respiratory control. This has been shown very clearly that it's not a good idea. And we have moved into a situation where we want to use the ventilator only to assist what the baby is doing, to amplify his effort, not to take over. So the idea today is to use synchronized IMV, assist control, or pressure support ventilation. And we will analyze why this is so important. And the aim, as Dr. Stetson discussed before, is to really move to non-invasive respiratory support as quickly as possible, because there is evidence that using non-invasive respiratory support significantly reduces the risk of lung injury and bronchopulmonary dysplasia. So the advantages then of using patient-triggered ventilation is that the infant will control his own respiratory rate. The infant will continue to breathe and therefore will reduce the pressure inside his chest, and this will reduce the negative effects of positive pressure on hemodynamics, and there will be less asynchrony, better synchronization between the patient and the ventilator, and this will reduce the incidence of hypoxemic episodes, will stabilize arterial blood pressure, and will also decrease the work of breathing. Perhaps the most important outcome related to the use of synchronized ventilation is that it will facilitate weaning. A baby who keeps breathing on his own, only assisted by the ventilator, is a baby that will come off mechanical ventilation sooner than a baby who is controlled, where you are determining his respiratory rate and his blood gas. So this is a meta-analysis of the studies that were done many years ago to compare synchronized ventilation with controlled mechanical ventilation. And what you see here is duration of mechanical ventilation. And as you can see very clearly, babies who were ventilated with synchronization, with assist ventilation, spent less time on mechanical ventilation. In terms of bronchopulmonary dysplasia, the evidence with synchronization is less clear. There is only this paper many years ago from Dr. Bernstein in San Diego that showed that babies who were ventilated with synchronized intermittent mandatory ventilation had lower duration of mechanical ventilation, 596 hours versus 801, and also had a lower incidence of bronchopulmonary dysplasia, 72 in the controlled ventilation versus 47 in the synchronized ventilation. So this study done in a relatively small number of babies, but very small, under 1 kilo, suggested that the use of synchronization could reduce the incidence of BPD. This is the only meta-analysis comparing synchronized ventilation versus controlled ventilation in these two studies. And only one, the one from Baumer, again suggested that moderate to severe BPD was lower, although did not reach significance. But the other study from Beresford, with a smaller number of patients, did not show any significance. So the effect of synchronization on BPD is controversial. There is no strong evidence in favor of this advantage. But as I mentioned, clearly synchronization reduces the duration of ventilation. There are some issues with synchronization that I think is important to keep in mind. First is that if you don't use the proper synchronization, you can have lack of trigger or delayed trigger, or if you have excessive sensitivity, you may have auto-cycling, where the ventilator will cycle at a much higher rate than what the baby is breathing. In that case, you will have insufficient expiratory time, and you may end up having gas trapping with over-distension. There is also a mechanism in all these ventilators to cycle off the inspiratory cycle. And this turning off, if it doesn't work properly, will end up with an excessive inspiratory time that produces essentially discomfort of the patient and fighting, or if it cycles off too early, will provide a very short inspiratory time, and that may compromise the tidal volume. So these are all things that you have to keep in mind and watch very carefully when you are using synchronized ventilation. Here you have a model where we induced a leak, and you can see then how the ventilator goes from a relatively low rate to a much higher rate of autocycling. And as I mentioned, this autocycling will induce a high rate, hyperventilation, hypocapnia, with negative results on brain perfusion, will increase mean airway pressure because you will have many more ventilatory breath, and will produce, as I mentioned before, inadvertent PEEP with depression of venous return and possibly decreased cardiac output. So very important to make sure that we avoid these complications really of synchronization. By far, the most common cause of autocycling is leaks around the endotracheal tube or water condensation in the ventilator circuit. So what can we conclude from synchronization? I think that there is no question that patient-triggered ventilation is much more comfortable for the patient and makes a lot of physiologic sense. That's how the patient will retain his normal respiratory control. It's associated with shorter duration of ventilation, is associated in some studies with reduced BPD in babies under 1 kilo. It reduces the number of hypoxemic episodes, but we have to make sure that whenever we are using synchronization, we are doing it properly, because if the synchronization is not working properly, we can induce more harm than benefit. Let's move to the other strategy that I want to discuss, that is volume targeted ventilation, also known as volume guaranteed ventilation. And I think that volume guaranteed is not a good term. I think we should talk about volume targeting. And essentially what volume targeting is that you give the ventilator the responsibility for adjusting the pressures, peak inspiratory pressures, to maintain or to deliver a tidal volume that you set. The clinician decides how many milliliters per kilo that baby needs, and then if the tidal volume gets smaller, like in this situation here, the ventilator detects that reduction in tidal volume and increases automatically the peak inspiratory pressure, re-establishing then a normal tidal volume. More important than this function, I think, is the fact that when you are using volume targeted ventilation, the ventilator also will reduce the peak inspiratory pressure if the baby is able to generate the tidal volume with his own respiratory effort. So here we switch from pressure limited ventilation to volume targeted ventilation at this point, and you see how the tidal volume gets more stable, and the peak inspiratory pressure that is required to generate this tidal volume is substantially lower than what we were giving to this baby when he was on pressure limited ventilation. So volume targeted ventilation provides an automated weaning of peak inspiratory pressure as the baby improves his lung compliance and improves his respiratory effort. There are several studies where these two modalities, controlled ventilation, pressure limited, and volume targeted ventilation, have been compared in premature infants. And the first the results shown very clearly in this meta-analysis is that volume targeted ventilation ended up reducing the duration of ventilation. Why is this? Because as I mentioned, volume targeted ventilation will wean the pressures as soon as the baby is able to generate a normal tidal volume. So shorter duration of ventilation. What about death or bronchopulmonary dysplasia, an outcome that obviously is of great interest to all of us? You see here that although most of the showed a reduction in the incidence of death or BPD, the effect is relatively modest. It becomes significant only when you analyze all these babies, all these studies together. None of them independently showed a beneficial effect. So the meta-analysis shows that death or BPD was 32% in the babies ventilated with volume targeted versus 43% in the babies that were ventilated with pressure limited ventilation. with a number needed to treat of 8 patients. We are careful in interpreting this data because many of these studies had some limitations in terms of study design. Each of them used different strategies for volume targeting in terms of initiation, type of ventilator, volumes used. And the most important point is that it's not clear what strategy was used in the babies in the control group. All we know is that they didn't receive volume targeted ventilation, but we don't know, we don't have much details in terms of what volumes, what pressures, what strategies for ventilation were used. So these are interesting findings, but I would not call this a very solid evidence that volume targeted ventilation reduces BPD. The other effect of volume targeted ventilation is shown in this trace in one of our patients when we go again from pressure limited ventilation to volume targeted ventilation. And this is a trace of pulse oximetry with saturations and heart rate. And you can see very clearly that this baby is having lots of fluctuations in saturation, like most of our patients when they are on mechanical ventilation. And we can see that these oscillations continue on volume targeted ventilation, but the severity of the desaturations is significantly less. And we have published 2 papers showing that this is exactly what happens in a group of patients where we compare pressure control versus volume targeted, where you can see that the frequency of episodes of hypoxemia does not change, it's exactly the same, but the duration of hypoxemic episodes below 85% and also below 75% decreases with volume target. What happens here? We know that these desaturations are many times related to fighting of the baby with the ventilator. The infant doesn't allow the baby to introduce a normal tidal volume, so the ventilator on volume targeted mode will increase the pressure automatically and the baby will recover from these episodes quicker. That's why the duration of the episodes then will be shorter with volume targeted than with pressure limited ventilation. So summarizing the results with volume targeted ventilation, this modality delivers more consistent tidal volumes, avoids excessive volumes, that is probably one of the most important characteristics of this modality. The other very important finding is that there is automatic weaning, and therefore there will be a shorter duration of mechanical ventilation. It also reduces the duration of hypoxemic episodes, and it may reduce death or BPD, although, as I mentioned, the evidence for this is not very strong. The limitations with volume targeted ventilation is that the adjustments that the ventilator does to maintain the tidal volume are based on the reading from a flow meter, that is a flow sensor in the ventilator circuit. And these flow sensors frequently fail or they may not give accurate readings. And that then will produce pressure adjustments, automatic pressure adjustments that are not based on true actual values, on accurate values of tidal volume, but of false values. The other limitation of volume targeting is that you have to be very careful with leaks, because some ventilators will adjust the pressures based on the inspiratory tidal volume. And if you have a leak, the inspiratory tidal volume is much larger than what the baby is really getting. Therefore, the ventilator will wean the pressures inappropriately. And the other limitation of volume targeted ventilation is that we really don't know what is the ideal tidal volume for each patient at each specific moment. So we usually say, well, yes, we'll target a tidal volume of 4 to 6 milliliters. Well, that may be appropriate for a baby with normal lungs. But a baby with severe BPD, for example, who has a very stiff lung, increased dead space, increased resistance, that baby may require a larger tidal volume to maintain acceptable PCO2s. So this is a limitation also of volume targeted ventilation. So in our institution, we don't use volume targeted routinely in all babies, but we mainly use it in babies with chronic lung disease who have frequent hypoxemic episodes, where we know that if we go to volume targeting, we achieve more stable levels of oxygenation and ventilation. But we don't think that this is a strategy that has been clearly shown to be beneficial in all extremely low birth weight injury. Only 2 words in terms of high frequency ventilation. Probably high frequency ventilation is the ventilatory strategy that has been most investigated in neonatology. You see here the number of trials from the early 90s to the 2000s. Many of them, and interestingly, many of the trials in the early years of use of high frequency ventilation suggested that use of high frequency would reduce bronchopulmonary dysplasia or death. And again, these were mostly babies under 28 weeks, under 30 weeks. As the time moves on and we go into the 2000s, you can see that the difference between high frequency ventilation and conventional ventilation in terms of PPD or death disappears. And I think that this is a very nice observation. And to me, this suggests that we really were probably not using conventional ventilation appropriately in the early stages of investigation of high frequency ventilation. And as we learn what I have described in the last few minutes, how to use a conventional ventilation in a more gentle way, the advantage of high frequency ventilation has disappeared. So in theory, high frequency should be advantageous because it provides ventilation with a very small tidal volume. And in that way, then reduces the risk of volute or barotrauma. And I think that without any doubt is an advantage, but normally we are using higher mean airway pressures with high frequency ventilation to maintain proper oxygenation. So we may be essentially canceling the advantage of using a low tidal volume with the fact that with high frequency we have to use a high mean airway pressure to achieve proper oxygenation, because if you don't use higher mean airway pressure, the lung tends to lose lung volume, lose FRC, and therefore the oxygenation decreases. So in summary, what are the strategies that we can use that are evidence-based to reduce lung injury associated with mechanical ventilation? First, let's try to avoid invasive ventilation at all costs in babies who have a normal respiratory drive. And this is what Dr. Stetson mentioned during his presentation. Let's use patient-triggered ventilation because of all the advantages that we mentioned, especially because of this allows the baby to breathe spontaneously and take him off ventilation sooner. Volume-targeted ventilation is a strategy that, as I mentioned, may offer some advantages, but it's much more complicated, and in our judgment, it has also some risks when the measurements obtained from the sensor, from the flow sensor, are not 100% accurate. Respiratory stimulants, we are going to talk about this in a following lecture. Permissive hypercapnia for extubation, especially in babies with chronic lung disease. I think we have to be conservative and allow PCO2 slightly higher than if we are weaning a baby on day 2, on day 3. Without any doubt, postnatal steroids are also helpful to get babies off mechanical ventilation sooner. And I think that the use of effective respiratory support after extubation by using slightly higher levels of nasal CPAP or nasal IMV or nasal IPPV are strategies that reduce the need for reintubation and also may reduce then the exposure to mechanical ventilation. This is a study that we published some time ago showing in babies under 1 kilo that the use of slightly higher levels of nasal CPAP after extubation reduced considerably extubation failure when compared with the babies that were extubated to the traditional levels of CPAP of 4 to 6 centimeters of water. These were babies on average of 14 days of age, of natal age. So I insist this always because we should not use higher levels of CPAP in babies during the early stages of HMD, where we can increase the risk of interstitial emphysema and pneumothorax. This was done, as I mentioned, in babies who were still ventilator dependent after the first week of life. And in this population, then, we saw that a higher levels of positive pressure could reduce the extubation failure and in that way eliminate the need for mechanical ventilation. So, repeating again, avoid invasive ventilation, avoiding excessive tidal volumes, either by using automated volume targeting, high frequency, or what I always emphasize, we get measurements of tidal volume from all the neonatal ventilators. So we don't necessarily need to use the automated system if our nurse or our respiratory therapist or our physician is watching carefully, and as soon as they detect excessive tidal volumes, they take the necessary action to avoid those larger tidal volumes. Aggressive weaning, very important, and obviously limiting the exposure to high oxygen is also very important. This is an interesting paper that was just published a few days ago that shows the trend of respiratory support in a large population of infants treated in units staffed by physicians from pediatrics. That is a private group here in the USA. And you can see how very clearly the use of mechanical ventilation, of invasive mechanical ventilation, has declined from 2008 to 2018 in this very large cohort, while at the same time the use of nasal intermittent positive pressure ventilation has gone up. The use of high flow nasal cannula has remained relatively constant. So there has been a clear a change in strategy of respiratory support using more nasal ventilation instead of invasive ventilation through the endotracheal tube. So is mechanical ventilation still an important factor in bronchopulmonary dysplasia? I think that without any question, this BPD, that was the original dysplasia described by Dr. Northway in the 60s, has become much less frequent. We still see occasionally some of these babies, but much less frequently than before. What we see today is more of a milder case of BPD labeled as new bronchopulmonary dysplasia. And I think that this huge reduction in the incidence of severe BPD has mainly been the result of the introduction of these non-invasive respiratory support modalities and the use of invasive respiratory support in a way that is less injurious to those lungs. So this is these are the points I just wanted to make, and I will be happy to answer questions later on during the discussion. Thank you very much.
Thank you very much, Dr. Eduardo Clary, as a really thought-provoking talk, and with continuation of that, the next topic is similar, which is the ventilatory management of severe BPD, the Children's Hospital of Philadelphia experience. It's my pleasure to introduce Dr. Kate Gibbs. She's the attending neonatologist in the Division of Neonatology, medical director of the newborn and infant chronic lung disease program, associate medical director of infant in the ICU in Children's Hospital of Philadelphia. He graduated from Loyola University in Chicago, did his her residency at Mount Sinai, New York, and pediatric fellowship is also in Mount Sinai, New York, and perinatal fellowship in Mount Sinai, New York. So she's actually my colleague, because I did all the residency and fellowship in the New York also. So then she moved to Children's Hospital of Philadelphia. He is the recipient of lots of awards and honor. In 2018, he got his Shivansari Faculty Teaching Award in 15 School of Medicine at Mount Sinai Institute of Medical Education Master Educator Award and Fellow of the Year Award and Attending of the Year Award and so on and so forth. So without further ado, I will ask Dr. Kate to discuss the another topic, the vulnerability management of the severe BPD, and then we will talk about caffeine, and then all of us discuss all this issue of this session in a panel discussion. So Dr. Kate, very welcome.
Thank you for the kind introduction and asking me to speak today at this conference. I'll be speaking about ventilatory management of severe BPD in our experience. We care for approximately 50 patients a year over the last 10 years. Sorry, and I have no conflicts of interest to disclose. Objectives today will be to apply principles of physiology to ventilator management in severe BPD, explain how we identify the phenotype of an individual patient, and then how we help that guide our ventilator management, and describe why we shift from an acute to chronic care management strategy for patients with severe BPD. So briefly, I think you all know that most infants with extreme prematurity will develop BPD. Overall, approximately 40% of infants, which has been stable rates over the last few decades. There are a number of definitions of BPD available. I think to define the population I'll be speaking about today, I'll use Eric Jensen's definition, one of my colleagues in our program, who developed a modern outcomes-based definition of BPD using a retrospective cohort of patients from the Neonatal Research Network. You can see had significant rates of death, serious respiratory morbidity, and neurodevelopmental impairments. And he developed 18 pre-specified severity-graded definitions to see how they could accurately predict later outcomes. One of them was the existing NIH definition, used a number of factors in a regression model, and the optimal BPD definition was the one that produced the highest C statistic for predicting late death for serious respiratory morbidity. This is the optimal definition of BPD that was the best predictor of the composite study outcomes. It took away the need to assess the 28 days of oxygen therapy and was based on the mode of support at 36 weeks postmenstrual age, which was irrespective of oxygen level. Grade 1 BPD is an infant that's on nasal cannula of equal or less than 2 liters per minute. Grade 2 is greater than 2 liters, or CPAP, or nasal intermittent positive pressure ventilation. And then grade 3 BPD is an infant who's mechanically ventilated. In terms of the rates by severity grade, about approximately 30% of patients will have what we call severe BPD, and those will be the patients that I'm speaking of today. Now, while a number of patients with grade 2 BPD will be on non-invasive support at 36 weeks, a proportion of these will go on to need mechanical ventilation later in time. And we use the same strategies for those patients. Looking at the outcome rates by severity, you can see that patients with grade 2 and substantially higher in grade 3 BPD have significant rates of death, morbidity, and neurodevelopmental impairments. And in looking at the outcome of death between 36 weeks and follow-up, you can see that grade 3 BPD is much higher than the other grades. Looking at respiratory outcomes by severity, again, you can see the pattern for grade 3 BPD, much higher rates of needing tracheostomy, hospitalization beyond 50 weeks for respiratory reasons, supplemental oxygen at follow-up, ventilator at follow-up, respiratory monitor use at follow-up. And so I think showing hopefully the significant chronic nature of this disease, I'm hoping to explain why we must move from our acute care approach that Dr. Bancalari just described so beautifully into a chronic care approach. And so when babies are first born, we target a lower tidal volume or pressure. We wean the ventilator support as much as we can. We frequent blood gases to guide this weaning, and we want to extubate as soon as possible. Now, when a patient meets the definition of severe BPD, we really do need to frame shift in our mind the reality that we now have a significant chronic disease, and we have to adjust our approach to the ventilator. So we increase our pressure limit to achieve our goal tidal volumes. We wean maybe once a week. We get infrequent blood gases, as the patient exam is just as meaningful to guide the settings. And in fact, we may intubate an infant who is failing to thrive on non-invasive support. So our global aim in ventilator management is to support the whole baby. And what do we mean by adequately supporting the whole baby? We have the lungs, but also the heart, neurodevelopment, and growth. And when we're looking to see if we're adequately supporting, we're not, as I mentioned, we don't really get frequent blood gases. We're looking at vital signs. We're looking at episodic desaturations. But also, can the baby participate in activities of daily living? Are they able to do anything other than lie in the crib? Are they having quiet awake periods? Can they handle cares? What happens when they ask them to sit up or participate in therapies? And in order to support the heart, we have to support the lungs. If we under-support the lungs, we inevitably see significant pulmonary hypertension develop. And if we don't support the lungs and the heart, then the baby can't participate in developmental therapies and as well as grow. And we look measurably at the bedside of weight and linear growth. And if we are inadequately supporting the baby, we'll actually see a continued weight gain, but linear growth will fall off. And so we use length boards to measure these babies once a week. And what we can't measure, but is just as essential, is the somatic growth. So the alveolarization and ongoing growth of the vasculature that's so essential. And so this means that we often will increase settings as the disease evolves. We think of BPD in terms of phenotypes, and these are data out of our program. And so the buckets that we place are lung parenchymal disease, which can be both homogeneous and heterogeneous, more commonly heterogeneous. And you can see in a CT scan on the right the heterogeneity of the disease there. Airway disease, that is both large and small airway disease. The small airway disease often has an obstructive and reactive component to it, as well as pulmonary vascular disease as a result of vascular pruning and remodeling, which can include both pulmonary arterial hypertension as well as pulmonary venous obstructive disease. And so we use a number of different modalities to try and identify the different phenotype for a different baby, which include bronchoscopy, CT scans, ventilator graphics, groupthink, echocardiography. Pulmonary hypertension is common in severe BPD. They have abnormal vascular growth, function, and structure due to impaired alveolarization and aberrant angiogenesis. And so ultimately you have those consequence of increased pulmonary vascular resistance and pulmonary hypertension. The true prevalence of pulmonary hypertension in BPD is unknown. Approximately 25 to 40% of infants will develop pulmonary hypertension, and these are primarily single center retrospective studies. In our 10-year experience, we've treated 46% of patients with inhaled nitric oxide and discharged a third on chronic enteral therapy. The timing of late disease development is also unknown, but likely broad. Again, single center studies with a range anywhere from 2 months to up to 56 weeks or 80 months post birth. So a very large range. It contributes to morbidity and mortality in BPD. And so and these are data from the Children's Hospital Neonatal Consortium, that BPD PH had higher rates of death before discharge, longer duration of mechanical ventilation, need for tracheostomy, discharge home on oxygen, readmissions. Mortality rates are as high as 50% by 2 years of age. However, in line with the fact that with good nutrition, growth, time, and support, we'll have ongoing alveolarization and lung growth, many of these infants will then be free of disease at approximately 60 weeks post-menstrual age. I would say that for a cohort of patients that we take care of, this is often in the years after discharge, and usually around the time for those who have a tracheostomy, around the time of decannulation. So how do we approach mechanical ventilation if there is established pulmonary hypertension? There's no specific adjustment to our approach, which we individualize to the particular baby's physiology, but to first support the heart, support the lungs is one of our guiding principles. And so we have a typical pattern where a baby will be admitted on high level of non-invasive support and has severe pulmonary hypertension and concerns for evolving right ventricular dysfunction or even overt failure. We have a low threshold to intubate them because we know that if we don't, their right ventricle will fail. However, they often do what I call is falling off the BPD cliff. And once you intubate them, they often are incredibly ill. We see this pattern in infants without pulmonary hypertension, where babies with bronchopulmonary dysplasia can just get by for a period of time on non-invasive support, and then with any intercurrent events can get quite ill. We screen monthly for pulmonary hypertension with echocardiography. We don't use serum markers for screening, but do follow once there's established disease. So we follow the two-compartment model concept in severe BPD to guide ventilator management, and that's that you have often multiple compartments in the lung. The healthy compartment is considered the fast compartment. This is relatively normal compliance and resistance. The injured compartment is the slow compartment with variable compliance, which can be low, normal, or high, and you can see again in this CT scan how completely different segments of the lung are. And we also see high airway resistance. And so as a result of this physiology, you target a lower rate in severe BPD. So as a reminder of time constant and resistance time compliance, and you get complete exhalation in 5 time constants. And you have variable time constants throughout the lung. That's why we use SIMV with pressure support over assist control, for example, so that you have variable time constants. In the graph here on the right, you can see that the volume, the total volume here is largely composed of the slow or injured compartment and then the fast compartment down here. With a ventilator I time of 0.5, the fast compartment fills very quickly and empties very quickly and is completely empty by 1 second. Whereas the slow compartment takes longer to fill, but even longer to empty. And so isn't actually fully empty until 3.5 seconds. If you take the math of 5 time constants with an expiratory time constant of 0.6, you get 3. And so if you use a rate over 17 to 20, you risk breath stacking. If you have breath stacking, you get incomplete expiratory time and contribute to auto PEEP. You also deliver a lower proportion of tidal volume to the slow compartment. And this is in contrast to respiratory distress syndrome, where you have short time constants, so you use a higher rate strategy. In this disease, airway resistance is normal and compliance is low. We also optimize lung volumes. Compliance is the change in volume over change in pressure. And so here's a pressure volume curve, and we follow these on the ventilators to try and determine where we are on the pressure volume curve. We want to be what's in the safe window here, and where you can see on x-ray, we're nice and open with minimal atelectasis. Most of my patients don't have an x-ray that looks like this, I will be honest. We want to avoid the zone of derecruitment and atelectasis where the lung is not open and we have significant atelectasis, and we're down here on the pressure volume curve, but also not end up in our zone of overdistension where we have such significant hyperinflation that we basically have significant high pressures. So our typical approach is volume targeted, synchronized, intermittent, mandatory ventilation. There's no protocol. We individualize it to each baby's physiology and phenotype, coming back to how are we supporting the lungs. So we start with tidal volumes approximately 8 to 10 per kilo. If they appear to be or more, we will certainly go higher into the 10 to 12 per kilo range and even higher if needed. Say mean peak inspiratory pressures in the 30s to 40s are quite typical, and they often need much higher. Our rate, I'll say here, there's some italicized because, as I said, there's no protocol, is usually less than or equal to 20. Inspiratory time is usually greater than or equal to 0.5. And our pressure support, we target slightly below the typical baseline pressures. So we're more attentive to the number, I'll be honest, if a patient remains tachypnic despite the goal tidal volume. And what we try to avoid is the pressure support higher than the vent pressure. So you can see here, this is a patient triggered breath in brown is higher than the ventilator breath, call that upside down. So if we see that happening, we'll then drop our pressure support. Our PEEP is not too high and not too low. And whatever the optimal PEEP is, and I'll go through that on the next few slides. And I'll say that the FiO2 often settles in the 30s to 40s for most babies. It is rare, it's possible, but rare to have infant need significantly high FiO2 for prolonged periods of time. Some frequently asked questions that I get is there a gestational age that we start to use the chronic settings? There aren't. It really depends on the physiology and the phenotype of the individual baby. Do we have a maximum PIP? No. We frequently will increase our pressure limit to exceed 50 to 60, if not higher. What settings do we extubate from? Generally, it's a PEEP in the 7 to 8 range. We don't wean below a tidal volume of 8 per kilo, assuming this is means in the mid to high 20s, sometimes low 30s, and again, FiO2s 30s, 40s. We do use other modes, and if that is what's best for the baby's physiology, absolutely. Do we use steroids to extubate? It depends. If the PEEP is too high and we don't think we're going to get the baby extubated during that period, we'll wait it out. If we get stuck on a PEEP of 10, then often we'll discuss and review prior exposure. We're getting infants in who have had 2, 3, 4 courses of steroids prior to even arriving to us, and they end up iatrogenically steroid adrenally insufficient, and so we're thoughtful about ongoing steroid exposure. So a recent example of a baby that came in on their admit settings, they came to us on pressure regulated volume control, a rate of 45, a tidal volume of 6 per kilo, a short eye time, a PEEP of 12, and an FiO2 of 100%. Over a period of the next 72 hours, we stood at the bedside and adjusted the settings. And, this doesn't happen all at once. We kind of, again, look at the baby, look at the vent, and slowly adjust. And here's where we ended up after 72 hours, which, as you can see, is a rate that's half, a tidal volume that's double, a pressure support that's higher, as well as the inspiratory time. And the FiO2 came down substantially with those measures. I'll use the ventilator graphics. It'll tell us an output of the minute ventilation. And so we'll often achieve the same minute ventilation as we make these adjustments. So how high, how low on the PEEP? I think this is honestly one of the biggest challenges that we have. I'm going to show the video on the right is a bronchoscopy of us really looking at the degree of airway malacia in a patient who was on a PEEP of 16 and still having intermittent episodic events. And so we were using this airway evaluation to try and adjust the PEEP to see if we could mitigate that collapse. We want enough PEEP so that the lung is open to recruit the lung, but we want to avoid PEEP excessive beyond what is needed, as Dr. Bankalari has described as well. And so we use the concept of matching compliance and resistance at a given PEEP to try and find what that optimal PEEP is. We use various methods to do so. In large airway disease, we do exactly this, which is we'll use direct visualization to say, as we go up on the PEEP, can we mitigate some of the collapse? This here is a PEEP grid that we can use by taking various PEEPs on the ventilator and measure the resistance and compliance output from the ventilator. I will say we don't use this to determine our PEEP, but we do use it as a general guide over a range of PEEPs. Where are we? This is an abstract that we presented at the Pediatric Academic Society meeting a few years ago, which described our PEEP use in patients referred to our program. It was a retrospective review of patients over 3 years for infants that arrived mechanically ventilated. And we split them out into 2 cohorts of PEEPs that were less than or equal to 10 over greater than 11 at admission. And we looked at the changes of PEEP and FiO2 over the 5 weeks after admission and various associations. The birth weight, the birth gestational age is very standard over the course of time for our program. and admission post-menstrual age was higher in patients with a tracheostomy, but otherwise it's pretty typical for patients to arrive to us around 43 weeks. And you can see there was a range of initial PEEPs. The average was ranged widely from 6 to 22, and over 5 weeks, we increased by an average of 2, but we also decreased PEEP in a third of patients. And the increase was associated with a modest but statistically significant decline in FiO2. In univariate analyses, PEEP over 11 at admission predicted discharge with a trach, and multivariable modeling, the need to escalate PEEP was associated with higher rates of trach or death. And notably, 70% of patients were discharged home with a trach. 90% of the entire cohort survived the discharge. Now, I'll say overall in our program in the last 10 years, we perform a tracheostomy in 40% of patients. I think what we took away from these analyses were that if we have a patient that arrives in mechanically ventilated past their due date, they are likely to end up needing a tracheostomy, but it's not an absolute. And so our average post-menstrual age at trach is 53 weeks. We do take our time, but if they're coming in with a high PEEP, we do take that into account when making that recommendation to families. This is a way to use the ventilator to identify optimal PEEP in the large airway phenotype. So with severe tracheobronchomalacia, you can see in the upper left-hand corner, on a PEEP of 12, the patient has no patient-triggered breaths. And we're seeing obstruction of flow and expiration. On a PEEP of 14, same thing, and you're seeing it actually in inspiration and expiration. At a PEEP of 18, you start to see the patient trigger, still seeing a little bit of obstruction. But at a PEEP of 24, this is kind of what you want your flow volume loop to look like, and our pressure volume curve has normalized. In the upper left-hand corner, the pressure shot up all the way, and when you have the opening pressure, that's when the airways were able to open. Whereas with a higher PEEP, you were able to have a more ideal pressure volume curve. Now, that doesn't say that this patient was left on a PEEP of 24, because again, we want to avoid excessive PEEP, but it's really a matter of identifying where, for large airway disease, how PEEP can help you. Now, excessive PEEP may exacerbate obstruction in the small airway phenotype, and I'll talk about that a little more. How do you identify a small airway phenotype? You can see here in the flow volume loop, the large airways empty quickly, and then you see that the flow stops here as you get to the smaller airways, whereas really you would like to see a nice rounded. And so when we see this pattern, we note that there's small airway disease. And given the degree of infants that are then responsive to bronchodilators, we'll usually at least assess a response to bronchodilators. Now, some infants with severe BPD are at risk for intrinsic or auto PEEP and dynamic hyperinflation. This is a consequence of alveolar simplification, poor stromal support, which contribute to the obstruction in small airway disease. I describe it as a stretched out rubber band. The alveoli just can't come back to normal at an expiration. And the consequence is auto PEEP, where alveolar pressure is greater than atmospheric at end expiration. You can see this in cases of large airway disease as well. And you can see this on ventilator graphics. You can also quantify it with an expiratory hold maneuver or esophageal manometry. But this graphic on the ventilator will show you that in the flow does not exactly return to zero before the next breath. And so if you're seeing this on the ventilator, there's some evidence that you have elevated alveolar pressure, which should be zero at end expiration. In this graphic here, you can see they're giving an example that the alveolar pressure is 10. And this is classic, also seen actually in COPD as well. And so what do we see is that the patients may have wasted breaths. So the top graphs that I showed prior, where the patient wasn't able to trigger, they're trying to trigger the ventilator. They're breathing, but they're not able to trigger the ventilator. The diaphragm just can't generate enough pressure to overcome the intrinsic PEEP. And so then as you increase the ventilator PEEP, as you start to approach intrinsic PEEP, you'll start to see the baby trigger, but this may not be sustained. And the challenge then is you are at risk for dynamic hyperinflation, where you have an end expiratory lung volume that can't return to resting volume. When you have severe dynamic hyperinflation in these pictures, you have significantly elevated intrathoracic pressures, and this contributes to dysfunction of the lymphatic system. In this patient here, his intrinsic PEEP was 24, and so we did not actually try and match his intrinsic PEEP, because what we see in this pattern is that we can match it for a period of time, but then the obstruction continues and it becomes a vicious cycle. The vicious cycle consequence is that you have such high intrathoracic pressures that you get a thoracic duct, a functional thoracic duct obstruction. And the consequence of that is severe lymphatic dysfunction, where you can see here in this patient, significant damasarca. This is dermal backflow from the lymphatic system into the skin. You can see chylous ascites, pleural and pericardial effusion. This patient had a cardiac arrest and we had to emergently drain a pericardial effusion. This is an MR lymphangiogram lighting up his thoracic duct, and all of this lighting up in his intestines is due to lymphatic leak into the intestines as well. These are patients that have severely simplified architecture, as seen in that CT scan, where they just have very, very, very simplified alveoli. And so identifying optimal PEEP in these patients with dynamic hyperinflation is a huge challenge. You can have too little and you can have too much. In large airway disease, higher PEEP absolutely can help you, and too little PEEP can add to dynamic hyperinflation. It's a consequence of needing that critical opening pressure to then allow expiratory flow to occur. However, in diffuse small airway disease, higher PEEP may decrease. So if you have diffuse small airway disease, PEEP actually may help stent open those floppy airways and then decrease your alveolar pressure. However, they can also further elevate alveolar pressure. And we really do need better technology to help us identify optimal PEEP in these patients. Complementary strategies that we use depending on the phenotype include inhaled nitric oxide to alleviate VQ mismatch. This may be in patients without any established pulmonary hypertension on echocardiography. We use bronchodilators in small airway disease. Other inhaled therapies to improve airway clearance. These children are at high risk for really smoldering lower respiratory tract infections. We use targeted use of diuretics. Prone positioning. We'll see this in patients that come in when we get a CT scan. You'll see posteriorly they're entirely atelectatic. And this is due to the fact that they've spent most of their time on their backs. So we really carefully try and do periods of prone positioning to try and recruit those posterior segments. We do use cuffed endotracheal tubes at times, not universally, to mitigate leak. And then, as I alluded to, if long-term positive pressure is anticipated, we recommend tracheostomy. Our average time is 53 weeks corrected, and we perform a tracheostomy in 40% of our patients. This is a huge ask for our families, which we acknowledge. And in the face of the pandemic, there's significant shortages of home nursing. And so it's one that we take very seriously. But is necessary to support the long-term lung health of our patients who really will need months, if not years, of mechanical ventilation. None of this would be possible without the input and guidance from the multidisciplinary members of our team, which is comprised of bedside nursing, physical therapy, occupational therapy, respiratory therapy, a whole multidisciplinary group of physicians who come together each week to think through the complicated physiology of these patients. This top photo here is Wyan Zhang, who started the program in 2010 and really has had an incredible vision for it. Thank you so much for allowing me to speak today, and I will return after hearing Dr. Bankalari's next excellent talk to answer any questions.
And this time he's completing this session with yet another talk of importance, caffeine indication versus abuse. We are all, I think, using it, but we are not thinking of abuse. So anyway, we will learn from it. So I think Dr. Bankalari, over to you.
Okay, good afternoon again. And the topic that I'm going to discuss now, it's very current. There is a lot of literature on caffeine use in preterm infants. And the views that I'm going to express are based on the literature, but also some personal experience. and it may be different from what you see in the literature most of the times. But I will be happy to take any questions at the end of the discussion. So apnea is one of the most common problems in preterm infants. The incidence is practically 80–90% in babies under 29 or 30 weeks. And most of the situations are related to a poor respiratory control, but there are a number of other issues such as airway obstruction, chest wall collapsibility, that also contribute to apnea of prematurity. But again, I'm just going to concentrate on the management. And the management obviously includes continuous monitoring, respiratory stimulants, and by far the most commonly used is caffeine. And unfortunately, there are many babies who will remain on a mechanical ventilator for long periods of time because of poor respiratory control. I think this is something that is very important we have to keep in mind. And the most effective therapy for apnea of prematurity is time, vitamin T, I call it, because we just have to be patient and wait until the respiratory control system matures to a point where these babies are able to maintain regular breathing and a normal minute ventilation. So all the other measures are temporary until the baby is able to maintain his normal respiratory pattern. So caffeine is a methylxanthine, it's a adenosine receptor antagonist that produces stimulation of central nervous activities overall, not only the respiratory controller. And I think that this is important because some of the side effects are related to this systemic effect. It increases also respiratory muscle activity, a weak diuretic. In the neonate, in the adult, sometimes it's very effective diuretic. You know that after drinking a few cups of coffee. Also has some anti-inflammatory properties. It does increase basal metabolism, and we are going to show some data on this. And unfortunately, also has some effects on circulation, both in the GI tract and in the central nervous system. So again, the point here is that caffeine is not just a respiratory stimulant, it's a very potent systemic drug that has effects on practically every organ. This was one of the first studies published by Jack Aranda many years ago, showing the effectiveness of caffeine, demonstrating a significant drop in the incidence of apneic episodes, although most babies continue to have apnea while on caffeine. So it's not that you eliminate it completely, and then again, this goes to the fact that this is an issue related to immaturity of the respiratory controller. It's amazing that probably the most commonly used drug in neonatology has very little evidence-based basis. These are the two studies that were used by the FDA to approve caffeine as a drug that could be used in premature infants. The first by Murad did not show a significant, showed a reduction in incidence of apnea, but this was not significant. In the second study that included around 70 patients only, published in 2000, this one barely showed a significant reduction in the incidence of apnea with the administration of caffeine. So this is just very interesting because again, so widely used and the evidence is relatively slim. Now, by far, the most important trial for caffeine was the CAP trial that was led by Dr. Barbara Schmidt, who spoke yesterday in this meeting. And this is probably one of the most significant trials in neonatology, included more than 2,000 patients. But this study really, although was done to evaluate the effectiveness and safety of caffeine, this really was not done to see how much caffeine would reduce apnea, but was really to see how effective it was in reducing the incidence of neonatal complications in general, but especially because there were concerns of negative effects on the neurodevelopment of these patients that could be altered by the administration of caffeine. So that was really the main driver of this CAP trial, and I think we have to keep this in mind. The other point that is important to remember is that in this trial, there was a caffeine or study group, and the other group was a placebo. And this placebo group did not get any medication. So although caffeine was known to be effective for apnea, the placebo group essentially was treated without the effects of a drug that was known to be effective in reducing apnea. So the results of this trial were very interesting. There were no differences in mortality or NEC, but there was a significant reduction in bronchopulmonary dysplasia. That was not the primary outcome, it was a secondary outcome of this trial. There was also a reduction in the incidence of patent ductus arteriosus, and therefore a lower need for PDA surgical closure. The concern of neurological effects was not an issue in the early evaluation of CAP trial. There was no evidence of differences in ultrasonographic findings between the two groups. And the only negative effect that was seen was that the weight gain was lower in babies who were treated with caffeine than in those who received placebo. In terms of longer-term outcomes, these babies have been followed for a period of 11 years now, and I wouldn't be surprised that Dr. Smith will continue to follow many of these babies. So at 2 years, it was very interesting because there was a significant reduction in death or developmental delay, and there was also a significant reduction in cerebral palsy and cognitive delay in the babies who received caffeine when compared with the placebo. So a significant advantage in terms of neurological outcome at 2 years of age. Later on, at 5 years of age, unfortunately, most of these advantages in terms of disability and lower IQ and disabling behavior pretty much disappeared. At 5 years, then there were no significant differences in any of the major endpoints were tested. And at 11 years, again, there were no differences between caffeine and placebo in most of the outcomes, except for motor impairment that was still significantly lower, significantly less common in infants who received caffeine versus those who received placebo. So a very interesting study where it shows that if we don't follow these babies for a long period of time, we clearly may miss some of the subtleties of the effect of a drug, caffeine in this case. The other point that we have to mention is that there was a secondary analysis of the data led by Peter Davis in Australia that was a part of this CAP trial. And what they found in this secondary analysis, dividing the babies in those who received caffeine during the first 3 days versus those who received caffeine after the first 3 days, was that the beneficial effects in terms of death or major disability, cerebral palsy, and BPD were more striking in those babies who were started on caffeine earlier than in those who were started on caffeine later. Now, it's very important that we realize that this was not a predetermined randomization. So the babies who were started early on caffeine was strictly because of clinician decision, and that immediately raises the possibility that we are talking about confounders in two different populations, essentially, that may confound this association between early caffeine and possible benefits. Anyways, after the CAP trial, and even before the CAP trial, you can see here that there was a very striking increase in the use of caffeine. And today, practically 80 or 90% of our patients, and this is from a study published by Dobson 7 years ago, most babies are getting caffeine, especially when they are born before 28 or 30 weeks of gestation. So caffeine has become, I think, the most common medication used in neonatal intensive care unit. So let's go back a little bit to when to start caffeine, because besides this increase in the utilization of caffeine, there has been also a trend to start caffeine as soon as possible. In fact, some people will start caffeine in the delivery room. There are some people that have even suggested that caffeine should be given to the mother, so the baby has the benefit from the very first minute of life. Let's see what the evidence tells us. First, we have the evidence from the CAP trial, where again the secondary analysis suggested that early caffeine would end up with better results. Ravi Patel did an analysis of a very large population in the United States, almost more than 10,000 patients, where he really could not confirm, could not see any evidence that early caffeine ended up with better results. Mortality, BPD, NEC, everything were essentially the same. Once again, this is not a prospective randomized trial. This is a retrospective analysis of clinical data, similar to what the CAP trial did. So there is an inconsistency here between the results of the secondary analysis of the CAP trial and this analysis of clinical data. We did a very small prospective control trial to again evaluate the possibility that starting caffeine during the first 72 hours in babies who were on mechanical ventilation may offer benefits in terms of limiting the duration of ventilation and in that way reducing BPD. We found that the total days on mechanical ventilation were the same in the two groups. So starting during the first 72 hours did not shorten ventilation versus starting before extubation. The total duration of oxygen was similar, and the incidence of BPD essentially was also the same. Both total BPD and severe BPD, no difference between babies started during the first 3 days versus started prior to extubation, that until we did this study had been the classic indication for the use of caffeine in this population, other than apnea, obviously. So we don't think that there is clear evidence that starting caffeine early in babies who are mechanically ventilated offers clear evidence-based advantage. Without any question, if you are trying to keep a baby off mechanical ventilation, supported by non-invasive modalities, then caffeine is the drug of choice to try to maintain minute ventilation and avoid the need of reintubation and mechanical ventilation in these patients. The next question that I want to discuss is how much dose. And like everything, when you see that something is good, then you ask, or many times you say, well, let's try it twice or 3 times and see if it's better. That's pretty much what has happened with caffeine. The point was, if 20 loading and 5 maintenance is good, why don't we try 20 milligrams per kilo per day of maintenance caffeine? And this was a study published 16, 17 years ago by Steer and collaborators. And what they saw, and this is really not surprising, was that extubation failure was less frequent in babies who received 4 times the dose of the conventionally treated group, from 30% down to 15% extubation failure. And the rest of the parameters were the same, although apnea, as again one could expect, was significantly lower in the babies who were receiving the higher dose. There was also a slightly higher frequency of tachycardia, but this complication or this side effect was relatively uncommon, so it did not reach significance. And there was no evidence of feeding intolerance. That was one of the concerns. And the time to regain weight was longer in the babies who were receiving 4 times the dose. And this was, as we will see in a few seconds, was related to a higher metabolic rate, most likely. The other outcomes of this study that included, as you can see, about 230 patients, was that IVH, grade 3 or 4, was more common in the babies who received the higher dose, but the number was very small, so there was no significant difference, no differences in ROP, but there was a borderline reduction in incidence of bronchopulmonary dysplasia in the babies who got the higher dose. In terms of neurological outcomes, there was also a trend to benefit in the babies who were getting higher dose, with a reduction in the number of babies with major disabilities that almost reached significance. Death and disability was also lower here, but this again crosses 1, so it does not reach statistical significance. But anyways, no signs of concern here for the babies who were receiving the higher dose. If anything, there were some indications that there could be a benefit. This is a meta-analysis that was published a couple of years ago of the 5 studies where the different doses of caffeine were compared in prospective randomized controlled trials. And as you can see, the only significant difference between high and conventional dose was that failure to extubation was lower, significantly lower, in the babies who received the higher dose of caffeine. That was the same findings from Dr. Steer's study. And there was a little bit more tachycardia, as we mentioned before, in this meta-analysis. None of the other endpoints, including BPD, IVH, ROP, mortality, etc., were different between the babies who received the high dose of caffeine versus the low dose of caffeine. Now, why should we think about this and in my judgment, be a little bit concerned? Clearly, when you choose 20 milligrams per kilo per day versus 5, you are, as expected, you achieving a much higher caffeine level with the higher dose. And this is obvious and totally expected. But you are reaching levels that are in the 60s or 70s, much higher than the ones that have been evaluated in most of the caffeine trials. There is evidence, and this is human data, that caffeine increases oxygen consumption, and this is at the normal doses. So it is very likely that using the high dose and achieving much higher levels will exacerbate this higher oxygen consumption. This, as I mentioned, may explain why these babies who are receiving the higher doses or are receiving caffeine versus placebo have lower growth rates. And the other reason why I think we should be concerned is because there is evidence in humans, and there is a paper just published recently showing exactly the same thing, that caffeine reduces flow in the carotid artery, the anterior cerebral artery, and also reduces flow in the superior mesenteric artery. So we have a situation here where this drug increases oxygen consumption, so increases oxygen demand, and at the same time decreases perfusion to some organs, including the brain. And this is obviously a combination that it's concerning. This is a study that was presented at PAS a few years ago, and now it's published, where these authors measured a cerebral oxygenation with a near-infrared spectroscopy, and they also used oxygen extraction. And you can see then here that the administration of caffeine produces a reduction in tissue oxygenation in the brain 1 hour after, that recovers partially after 6 hours. And because there is increased consumption and reduced oxygenation, there is also increased extraction of oxygen from the cerebral circulation. So again, I think that these are things that we don't know exactly what is the significance, but obviously if you have an organ that is requiring more oxygen, extracting more oxygen, and is getting less flow, that is of concern. The other piece of information that I think is very important is this one. Many people list the anti-inflammatory properties of caffeine as one of the reasons to use it, and to use it earlier and at higher dose. Well, there is this paper published several years ago, 10 years ago already, where these authors measured a number of inflammatory mediators in a group of infants who were receiving caffeine and correlated the levels of inflammatory mediators with the level of caffeine in the serum of these neonates. And you can see that the concentration of inflammatory mediators drops as the levels of caffeine increase to 15 micrograms per milliliter. That is usually the blood level that we try to maintain in these patients. But as the levels increase to 25 or 30, actually most of these inflammatory mediators increase. So we have to be very careful because the anti-inflammatory properties of caffeine may be level mediated. And although it may be anti-inflammatory at the levels that have been evaluated in most of the studies, if these levels are pushed much higher, we may have essentially the opposite effect. The other reason why we are concerned about high levels of caffeine is this study from the group in Boston, where they gave 80 milligrams per kilo IV as a loading dose, followed by the traditional dose of 5 milligrams per kilo to babies who immediately after birth. This was a dose given immediately after the babies were born during the first hours of life. And they followed then MRI findings and neurobehavioral testing in these babies at term age and at 2 years of age in this population. What they found was that the MRI showed a higher incidence of cerebellar hemorrhage, 36% versus 10%, in the babies who received this very high dose of caffeine, 80 milligrams per kilo per day. This was the only difference, but obviously very concerning. Not only there was a higher incidence of cerebral hemorrhage, but in follow-up, these babies had also increased hypertonicity when they were compared to the babies who received the normal amount of caffeine, the 20 milligrams of loading dose. In another study published more recently by the same group, there was also, where they also compared 80 milligrams per kilo versus 30 milligrams per kilo of loading dose. They found that the seizure burden in terms of proportion of babies having seizures, but especially the duration of seizures, was longer in the babies who were receiving who received the higher loading dose. This did not reach statistical significance, but again, we all know that aminophylline or caffeine at excessive doses can reduce the seizure threshold, and therefore this effect is really not surprising. So I think that there are a number of signals in the literature that should make us be careful before we start pushing very high doses in these patients. What about the duration of caffeine? This is a very old study where these authors showed the post-menstrual age when the baby stopped having apnea. And you can see that apnea decreases as postnatal corrected age increases, and usually by 32, 34 weeks, the proportion of infants that still have apnea has been reduced substantially, and that's why in the older literature it has been suggested that babies can be weaned from, or at least started to be weaned from caffeine after 32 or 33 weeks. And I think that that's what most clinicians have done over the years. However, there is some data suggesting that if you keep some of these babies, especially if they have unstable respiratory patterns on caffeine, shown here in the open squares, they will have much lower incidence of hypoxemic episodes than babies where the caffeine is discontinued earlier. So there are trials going on now here in the US trying to assess what is the effect, or what is the benefit, the potential benefit of maintaining babies who still have a pattern of unstable respiratory control for a longer period of time, and they are even being discharged on caffeine, discharged home on caffeine with close monitoring. So the question of how long should we treat these babies is still open, and I think that we have to look for the evidence when this result published. So in conclusion, I think caffeine is clearly a very effective drug to reduce apnea of prematurity and also to improve extubation success. I think that here the evidence is very solid, and this is the classical indication for caffeine. It's not clear if caffeine always reduces the incidence of hypoxemic episodes, especially in babies who are ventilated, where these episodes may be related to agitation. Caffeine, being a central nervous system stimulant, may in fact make these episodes of agitation more severe or more frequent. But again, this is just a speculation. We don't have data on this yet. The proper dose and safety of caffeine, it's not well established, but there are a number of publications suggesting that higher doses and higher levels may be associated with negative side effects. Therefore, we are very concerned with the use of substantially higher doses of caffeine when they are not indicated. There is no clear data on the effects of caffeine on the incidence of BPD or PVA as primary outcomes. Again, there is some evidence, and the best evidence is from the CAP trial, but as I mentioned before, the CAP trial, the control group did not get caffeine for apnea or for extubation, that are indications that are clearly established and that may reduce the incidence of BPD. So the effectiveness and safety of prolonged and aggressive use of caffeine, in our judgment, is not well established. So I think that although there is a lot of literature, scientific and less scientific, suggesting that caffeine has a number of positive effects, lower risk of death, less cardiovascular disease in the adult, there are a number of signals in the literature, both from clinical studies and from animal studies, that suggest that actually the caffeine effects and benefits may be related to the amount of caffeine, and that using caffeine at excessive doses actually, or using it longer than what is indicated, may not be beneficial. In this study, this investigator that has done a large amount of investigation on caffeine in animals specifically, states in this commentary that while moderate dose of caffeine appears to be clinically beneficial for preterm infants, assessment of cellular and molecular effects of caffeine in developing brain using animal models suggests otherwise, with most studies suggesting that caffeine has adverse effects on the developing brain regardless administered. And to make the situation even more concerning, there is this study that was just published a few months ago in adults, where they showed that drinking 6 or more cups of coffee a day was associated with smaller brain volume and 53% increase in risk of dementia. So their conclusion is that with coffee intake, moderation is the key. Especially high levels of consumption may have adverse long-term effects on the brain. Again, this is from adults, not related to newborns, but I'm just sharing this data because I think in a neonate, the vulnerability for many of the interventions we do may not show up until many years later. And I think we have to be very careful. And our recommendation is to stick to the classic indications and classic doses of caffeine until there is clear evidence that a different strategy is effective and safe. So to close, I just like to invite all of you to our Miami Neonatology Conference that will be taking place in Miami Beach between the 15th and the 17th of November. This year it's going to be in person and on the web. So you can choose whatever participation is more appropriate for you. Thank you very much again to the organizers of this excellent conference. I really enjoyed being part of this excellent activity. Thank you very much.
Okay, thank you very much again, Dr. Vanflari, and thank you, Dr. Kate. So we'll start with the questions. I will start with the first question to Dr. Vanflari about the strategies of the lung ventilation. So most of us using the volume targeted plus assist control, and Dr. Kate is using SIMV. And is the question for both of you: is there any difference, or is there a preference? Dr. Kate suggested it depends on the baby physiology. So, what do you think? Well, it's a question for both of you. But here we are using assist control plus volume targeted or volume guarantee. Is there any way we can define that one is better than this one?
Hey, do you want to start?
Anyone of you start?
Okay.
Yeah.
Well, I think that if you go by the evidence on volume targeted ventilation, you have all the support to use volume targeted, because again, the suggestion is that you can reduce duration of ventilation and that you can maybe reduce bronchopulmonary dysplasia. As I mentioned, we are not convinced about the strengths of the evidence on BPV. And on the other hand, we have been using volume targeting for more than 20 years. We actually helped some of the companies to develop volume targeting when Dr. Gerhardt was part of our members. So it's not that we are uncomfortable because we don't have experience. We are uncomfortable because every time we use it, we see that it's a strategy that requires much more knowledge, much more certainty in terms of what each ventilator. We don't have time to go into that, but there are all sorts of different algorithms, different systems that produce volume targeted. None of these things have been evaluated in any systematic way. So we are very worried. And again, the first equipment, what algorithm the equipment is using, accuracy of the flow sensor are crucial. If those things are not working, it can do much more harm than good. And the main limitation in our judgment is what tidal volume do you use? If you are targeting a tidal volume that is insufficient for a certain patient, what happens? The baby will start making more effort, will move a tidal volume larger than the one you are setting, and the ventilator will win the pressure completely, because we'll think that the baby is getting a tidal volume that is excessive. So you are targeting 5. This is a chronic lunger who needs a tidal volume of 6 or 7. He increases his effort to get that 6 or 7, and the peak pressures are win. So this is, and you see the baby struggling, okay, to breathe. All the effort has been essentially passed to the baby. No good situation. I think it's very good. It's very poor. Now, the other side is that if you are using a tidal volume that is higher than what the baby requires, usually you will lower the CO2 below the apneic threshold, essentially. The baby will be very happy, will not be breathing, because he will be getting a tidal volume that is higher than what he is set for. And essentially, you are passing all the responsibilities to the ventilator. We see this happening all the time in our own unit with patients. And the tidal volume that now may be 5 or 6, tomorrow may be 7 or 4, what the baby needs. These are dynamic changes, as Dr. Gibbs explained very nicely. So it requires much more knowledge, much more being on top, and perfect equipment to achieve this. And we feel that this is not easy to achieve in most neonatal ICU. So that's why we don't use it routinely on everybody.
And Dr. Gibbs,
I
you have a
have,
comment?
I have, I just have a question to Dr. Bangalari about the use of high frequency as a primary mode in effort to decrease the BPD. As you mentioned, prior to 2000, we used to use high frequency as a primary mode, thinking that that's to decrease BPD. And then came along the HiFi study, which is showed increase the IBH grade 3 and grade 4, and if you do that as a primary mode. Now, we recently listened to a presentation from University of Iowa. They use high frequency as a primary mode, but they use a jet ventilator. So my question to you is that do you have any comment about any advantage of using the jet ventilator over the high frequency oscillator ventilator in the BPD prevention strategy?
Yeah, we used jet ventilators many years ago, but at this we have not used it now in many years. So we really don't have experience to tell you what we do and how do we manage the decision of one versus the other. In our judgment, there is no good control trial comparing high frequency jet with high frequency oscillatory ventilator to make this decision. And as I mentioned, and I showed the data from Ulrich Thome, we don't think that the evidence in recent years is strong enough to recommend high frequency oscillation routinely in all preterm infants. And the main reason is that high frequency oscillation is a very effective strategy to wash out CO2. So in our center, we use it usually as a rescue in babies where the CO2 is going up and we're not comfortable escalating the peak inspiratory pressures. But in terms of oxygenation, if anything, usually you see a loss of oxygenation. And that's why most of the times you have to use high mean airway pressures when you switch from conventional to high frequency. Now, the main reason why we don't use high frequency is because our philosophy is to use mechanical ventilation to support the spontaneous breathing of the patient. And the babies don't breathe at 10 hertz or 15 hertz. So there is no way that you can do any synchronization or anything when you're using high frequency. Usually you lower the CO2 below the breathing threshold of the baby. So most of the kids get apneic when you're using high frequency. And we think that most of the evidence, as I mentioned in the first talk, is that the best thing you can do is to let your patient breathe and use your ventilator to support, to amplify the breathing. You cannot do that with high frequency. So that's why we prefer to use routinely conventional and not high frequency. I would be very interested in hearing Dr. Gibbs on her experience both on volume targeting and on high frequency, because again, in a children's hospital, they have a completely different type of population.
Yes, Dr. Gibbs.
So I'll say in our typical small baby unit, so our hospital at University of Pennsylvania is our inborn unit. We do use volume targeted for the ELBW infants. The Draeger baby log, the microprocessor with the latest iterations, is pretty sophisticated, and you can get down to low tidal volume. So I would say that's the general strategy. And then we do use jet. It's generally if there's PIE, we don't use it on everyone. So I think jets, if there's interstitial emphysema, we'll move to the jet or air leak. And then the oscillator is certainly used for the severe respiratory failure in those infants. So I would say it's a mix. And I think if there's a significant leak, then you'll move to pressure control in the small one. So we use all four. At CHOP, I'll say the patient population is all outborn largely. The special delivery unit doesn't deliver. We don't have many inborn small babies. And so the patients are quite sick. But I'll say generally, again, we're using volume target.
Question, Dr. Gibbs, about your case presentation where you have a patient admitted to your unit and PRVC and 100%, and then you switch to SIMV, and then you have successfully decreased the oxygen to 40 or 60%. Now, what's your explanation to this? Because we're thinking about PRVC is the more synchronized and the more, patient-triggered ventilation where SIMV is only trying to synchronize. So what's the explanation of this drop in the oxygen requirement when we move from PRVC to SIMV?
So I don't think it's necessarily PRVC alone. I think it's the fact that we frequently will get children in using the small baby strategy of lower tidal volumes, higher rates, and their disease is just so heterogeneous that their lungs need that higher tidal volume and then the longer expiratory time to really get their mechanics into an ideal place. I think that's probably where we see the impact is larger. We don't use PRVC because, like I said, we have the Draeger baby logs. And I'll just say that from our perspective, the ventilator for these patients is what matches them. I don't have anything against PRVC in itself, other than we don't have the ventilators that have those.
So you don't use NAVA ventilation of those older babies on ventilators.
And I'll say the other element of PRVC is my recollection, having used it historically, is it's really an assist control mode. So you've got one eye time. That could be different on different modes. But again, that's why we move away from assist control as a universal approach, is because you then are only delivering one inspiratory time. For NAVA, there are no data on NAVA in severe BPD, so we're going to try and contribute to the field for that. Eric Jensen has an active research study planning to do crossover NAVA to conventional ventilation, and study that and hopefully contribute that in, because there are no data. I will say that at our recent collaborative meeting, there are centers that are using NAVA in BPD. But I think it remains to be seen whether or not it's a strategy that meets their needs.
Yeah, I have two questions for Dr. Gibbs. First is there any other way to estimate the required PEEP other than bronchoscopy?
In terms of identifying optimal PEEP, we'll use the ventilator graphics. So the flow volume and pressure volume curves, we'll use that, and how open is the patient on X-ray? How are they synchronizing with the ventilator? The kind of overall state to find optimal PEEP. I think for large airway disease, direct visualization of the airway and a dynamic airway evaluation is incredibly helpful, because you can see at a PEEP of 17, you're ameliorating that collapse. For small airway disease, obviously they're not going to get down, and that's small airway disease is where finding the optimal PEEP is that much more challenging.
There's another question that I think this is for both Dr. Ranklari and Dr. Gibbs, that for BPD, other than ventilation, what we discussed, what are the uses and what are the advantages of diuretics and bronchodilators or any adjunct therapy? How big believer you both are on this, especially the diuretics?
So diuretics are incredibly commonly used in BPD. Nick Bammond is another one of our physician scientists who has is funded through the NIH to actually study the pharmacokinetics and dynamics of furosemide in BPD. And so I'm excited to see those results over time. Certainly, we use them. There's significant diuretic use. I think the challenge becomes that the kidneys are smarter than we are, and then you get tolerance to the therapy. So I think there absolutely is a role. I think it's a matter of then what response are you for, and ensuring that you're actually seeing a response.
Yeah, we have gone through different phases with the use of diuretics and the bronchodilators. Many years ago, we used to have all our patients on chronic diuretics, and after realizing how many complications we can induce with that, and the evidence also became much more clear in the literature, we have become much more conservative with the use of diuretics, and we use them only when there is clear evidence of pulmonary edema, and usually we indicate them for 2 or 3 days, restrict fluids, take any of the other measures to improve the edema, and then stop them. The complications, again, it's calcium loss, nephrocalcinosis. They all develop a significant metabolic alkalosis that ends up producing more depression of respiratory drive. So we we are very reluctant to use chronic diuretics. We use them only acutely for specific indications. And with bronchodilators, pretty much the same. If you keep a baby on bronchodilators, you will pretty soon have tachyphylaxis. They don't respond anymore, and all you will see is the tachycardia and the side effects of the bronchodilator. So we do use them, but only during acute episodes of deterioration and clear evidence of airway obstruction, especially clear evidence of response. I think that there's nothing wrong if you see that a baby is struggling, is having wheezing, the CO2 is going up, try diuretics by all means and see. If you see a response, you can see, looking at the graphs in the ventilator, the way Dr. Gibbs showed in her patients, and looking at the gases and so on, if there is a response, you can continue. But if you don't see a response, keeping them on prolonged chronic medications most of the times does more harm than good.
There's some couple of questions about caffeine for Dr. Bancalari.
Go ahead.
One about any difference between IV caffeine versus oral caffeine in the start. And the other question is that when to stop caffeine.
Yes. So in terms of IV versus oral, one of the beauties is that caffeine can be given either way, and you can achieve levels very nicely also with oral caffeine. So what matters essentially is how much you are giving and not how you give it. One comment I would like to make is that most of the literature suggests that you don't have to measure levels with caffeine. You just watch the baby, and if the baby has apnea, you just give a little bit more. If it doesn't, you just keep the same dose. We think that is the wrong approach. Like any other medication, especially in neonates, there is a tremendous variability in caffeine levels in preterm infants. In the same baby, as they mature, they clearly metabolize caffeine much more effectively, and the levels go down. So we do measure levels, and very frequently find that the levels are way too low and we have to increase. And sometimes we are surprised because the levels are higher than what we would like to do. So I think that especially if you are using oral caffeine, probably is wise if you have the possibility to measure levels and make sure that the baby is absorbing it. And the other question was
when to stop caffeine.
When to stop the caffeine. Yes, that, as I mentioned, that is a question that is still open. Most of the times we start weaning caffeine around 32, 34 weeks of corrected age. And if the baby doesn't have any significant apnea or bradycardia, we continue to wean until we stop the caffeine before the baby goes home. But now Carl Hunt and his group, who has been doing studies on control of breathing for many, many years, is doing the study that is supported by NIH, because they have done much closer monitoring, and they have described that a good number of these babies continue to have apneic episodes and desaturations after 34, 36 weeks. So they are doing this prospective randomized trial where they are discharging some babies on caffeine, monitoring them carefully at home, versus the control group where the caffeine is stopped by the clinicians earlier. And we'll have to wait until those results are out to answer more precisely the question, when should we stop caffeine?
So just, I know we are running late, but just one or two questions. Dr. K, there is one question about of course, the mode of ventilation is very high, but even in the cases of the BPD, we never use that high beam. So can you elaborate again the TAN beam or the pressure of that much high?
Yeah, I think we are kind of known for using robust amounts of PEEP. And I think the consequence of that is in some patients, we've now seen this very severe lymphatic dysfunction, and it may or may not be associated, honestly, with the PEEP. The other disclosure is that we get the most severe of the most severe patients. And so these patients have incredibly distorted lung architecture. And so I would say most of the patients right now in the unit are on a PEEP anywhere from, 10 to 14. But if we've got a patient on a PEEP of 7 and 8, we're excited because we're moving towards extubation. So they just, for a period of time, it does appear that to achieve opening up those floppy, large and distal airways, they do seem to need more PEEP than they certainly needed when they were much smaller. We don't use that much PEEP in the ELBW infants by any stretch.
Okay, Dr. Eamon, do you have any further questions?
We have one question about any risk of oral caffeine in necrotizing enterocolitis, in causing necrotizing in this.
Yeah, there is no data to suggest that oral caffeine will have a higher incidence of NEC. But since they asked the question, it's interesting because the trial that was used by FDA to approve caffeine use, again, included only, I think, were 60 or 70 patients, and there was a larger number of babies in the caffeine developed NEC than in the other. It was not significant, so FDA went on and approved the use of caffeine. Now, the good thing is that all the others done afterwards, including the CAP trial with 2006 patients, have not shown any evidence that caffeine is associated with NEC. So I think that is a risk that doesn't seem to be there with caffeine.
Thank you.
So that's all. Yeah, I think we have to, because we have another session. Thanks a lot, Dr. Panclari and Dr. Gibbs. It's really very, very fruitful, and all the participants are, it's more than 1,800 delegates are logged in right now listening to you. It's more than 50 countries. So it's a very comprehensive review of BPD and ventilation. Thanks a lot, and maybe next year, Dr. Panclari and Dr. Gibbs, we have to see you in person.
Hope to be there.
Thank
Thank you very much.